Communication skills, communicating with patients and relatives. When, during admission and before discharge, on ward rounds, during clinical examinations and procedures, when the results of treatments are known and management changes, in outpatient clinics. Where to maintain the patient's privacy. This is particularly important on an open ward. Knock on doors and close them after you. Draw the curtains round the bed. Ask a nurse to accompany you, particularly if you are explaining something complex or breaking bad news. They will have to answer the patient's and relatives' questions when you have left the ward or clinic room. How? Know your facts. Are you giving the right diagnosis to the right patient? Are you equipped to consent a patient for the surgical procedure? Sit at the same level as the person to whom you are talking. Maintain appropriate eye contact and introduce yourself. Find out what the patient knows and what they are expecting. Listen. The patient's own knowledge, state of mind, and ability to grasp concepts will dictate both how and how much you explain. Tell the truth. Know your facts, be sensitive to what the patient may not want to know at this stage, and do not lie. Avoid jargon. Chronic may simply mean long-standing to you. To most patients, it means severe. Avoid vague terms. Try to describe risk quantitatively, a 1 in 100 chance, rather than qualitatively, a small risk. Check that the patient understands. Don't assume that they do. Help the patient to remember. Use information booklets, draw diagrams, write instructions down. Maintain a professional relationship. Never allow your personal likes, dislikes, and prejudices to hamper your clinical skills. Breaking bad news. Is there a relative or friend whom the patient might wish to have with them, who may be a source of emotional support, as well as being better able to retain information? Know what options, if any, are available. If a cancer is inoperable, is chemotherapy planned? If an operation is canceled, when is the next date? Do not be afraid to stop to allow the patient time to gather their thoughts and emotions and recommence at a later time. Do not mistake numbness for calm acceptance and try not to take anger personally unless the bad news is actually your fault. Communicating with nurses. Introduce yourself on arrival to the staff nurse in charge. Establish early on which nurses are experienced. The help you get from them will be different from the questions you get from others. In theater, scrub nurses are not the enemy. Your inexperience is. Try to remember all their names as they will remember yours. Do ward work efficiently. Recognize how important it is for the smooth running of the ward that your ward rounds, note-keeping, prescriptions, and discharge letters are timely and accurate. Let the nurses know when you are going for lunch, teaching, or sleep. If they can discuss problems now, it will save you being paged later. Do an evening ward round to check on problem patients and drug requirements. Your sleep is less likely to be constantly interrupted. Communication with hospital doctors. Don't refer without first asking your consultant or registrar. When making requests for clinical consultations, write a concise but clear letter in the notes to the appropriate clinician. When asked to see a patient, go the same day. Write your opinion in the case notes, stating clearly what you recommend, and always discuss it with the seniors on your own firm. If a preoperative patient is complex or has significant comorbidity, contact the appropriate anesthetist. They will help you ensure that the patient is adequately prepared for surgery. Communication with general practitioners, GPs. The GP has usually looked after your patient for years and, however, inspired your diagnostic or operating skills. They will be there to sort out all the complications that are hidden from you once the patient is discharged. They often know your consultant well. So think, telephone the GP in the case of a death of a patient, if you unexpectedly admit a patient, or to help with a difficult discharge. Write useful, legible discharge summaries. What would you want to know if you were going to have to wait 4 weeks for the typed discharge letter to arrive? At an absolute minimum, the date and name of the operation, post-operative complications, and plan. Keep clinic letters clear and concise. Radiology and laboratory colleagues. Know exactly how the investigation will change your management. If there is doubt about the correct investigation, telephone for advice. Complete request forms correctly and include clinical data. It can make a big difference, particularly if you have requested the wrong test. Administration. Introduce yourself to your consultant's secretary early, find out how they like things run, and then run things their way. They will usually have more than typing input on your reference. Produce GMC, Defense Union, occupational health, holiday, and study leave paperwork with good grace. They are mostly legal requirements, and being rude won't change that. Always used in case control studies and appear in meta-analyses of case control studies. The basis of logistic regression analysis. Statistical significance. Studies are designed to disprove the null hypothesis that findings are due to chance. The p-value is the probability of a study rejecting the null hypothesis if it were true, a type 1 error, i.e., finding a difference where none exists. Statistical significance is commonly taken as a less than 1 in 20 chance of this happening, i.e., p.05. Power is the probability of detecting an association if one exists. Underpowered trials contain too few patients and may make type 2 errors, accepting the null hypothesis when it is false, i.e., finding no difference where one does exist. 95% confidence intervals, derived from the mean and SD, are the range of results predicted if the study were repeated 95 times.